Good evening. Everybody hear me okay? All right, so we'll try to get through this fairly quickly. If there's anybody sleeping, I will be pointing you out. I may throw a pen at you if you snore. So I'm Dr. Kozfkay, Dr. K. For those of you that don't know me, I see some of my patients here. I do have a couple patients here that have been treated with these therapies, and they may or may not want to share their experiences at the end. Jason is here. He's one of my first treated. He's pushing, there he is. I don't have any ice to throw at you this time. He's pushing probably 3.5 years from one treatment and still getting relief. So he's not an actor, although he may look like one. He's very good. If you've been on our website with a testimonial, and then we have a recent patient somewhere. If she wants to make herself known, she will. Is that better? Can you turn it up at all, Dan, or no? How's that? Okay, so as in the email you got from us, we're going to be talking about regenerative medicine today, and we have a couple pictures here representing the focus of the discussion, okay? And you'll see them again later in the talk. We'll be going through some questions at the end too. I'd ask that you hold them until then. So once again, regenerative medicine will be focusing on bone marrow aspirate concentrate, which I like to call BMAC, and then platelet-rich plasma, which we call PRP. There are a couple other quote-unquote regenerative techniques which we will not be discussing. Adipose tissue, which I may offer in the future. And then there are a variety of other cellular products that are obtained from other people, amniotic tissues, umbilical cord tissues, placental tissues. Those are all dead cells coming from another person. We currently don't offer them, and I don't plan on offering them in the future. So if you do see some, marketing, this is a pretty heavily marketed procedure currently for a variety of reasons, just to make sure you know what you're getting yourself into. So we're going to be talking about osteoarthritis in general. I just want to make sure everybody understands what it is, why it's there. We're going to review anatomy, then specifically talk about PRP and BMAC, and once again, finish with some questions. Riley's also here. He's a representative from the company that I use their products, and he can also answer some questions for you if I'm not available at the end. So, osteoarthritis, what is it? It's a degenerative joint disease. Can happen from wear and tear, depending on your occupation. We find it more in women. Depending on your weight, you may be more apt to develop this also, as well as your age. Then it also runs in families. We're not as mobile as we used to be. We do find immobility can lead to arthritis also. And it does affect a lot of the population worldwide. Up to 43 million people do have moderate to severe disability from osteoarthritis. So, getting into anatomy, we're taking a look at a knee joint here. So, on the left, we see a normal joint space. So you have good space in between the bones, the top and the bottom. You do not see any bone spurs, or what we call osteophytes. You don't see any sclerosis, which is brightening of the bone, and you don't see any bony cysts. On the other side, we see something we call a grade 3 arthritic knee, which would be moderate to severe. So here you can see you've lost some joint space compared to the other side. You've developed a quote-unquote bone spur, and then you've got some brightening of the bony tissue underneath. Right there. Okay. Other things we can see are bone cysts that develop underneath the cartilage. But there's actually a lot more going on. So whoever's showing you your x-ray or discussing the x-ray with you, osteoarthritis is a very complex, dynamic process. So this is actually more what's going on within your knee, and this is probably one of the main points I want you to take away tonight in regards to osteoarthritis. It's not a simple process. It's not just a loss of cartilage. It's not just a bone spur. Everybody has bone spurs here, even myself, and they're not necessarily causing you pain. So if somebody tells you you have bone spurs, don't get too worried about it. It's a pretty normal part of the process. So, what is causing pain then? So when we take a little more in-depth look at a joint, there are a lot of things going on. We have a synovial membrane here. That can be painful. We have joint fluid. That can also be painful. Where'd my pointer go? There it is. Okay, so the joint fluid can be painful. The bone itself can be painful. And then you can have also some issues with the cartilage. So this is a pretty dynamic process. Once again, you can have pain at multiple sites around the joint, and also what you don't see here, some insertion sites for tendons, ligaments, that can also be painful. Okay? So what happens is you have an injury, this process takes off, you basically have products that are inflammatory, and your body's response to that is to try to shut it down with anti-inflammatory products. And there are a variety of different enzymes and proteins that are involved in this process. And this is just a close-up view of what's going on within the joint fluid. So once again, we have this battle between pro-inflammatory and anti-inflammatory. So typical treatment options, exercise and weight loss. Just a 5% loss in weight can make a difference in how you feel in an arthritic joint. That's very important. We may not maximize that enough, but that is always number one. After that, there are a variety of medications, physical therapies, and injections. And when those typically fail, classically, we move on to surgery. Many of you probably have had some sort of knee replacement or hip replacement at this point. It's a significant cost to the U.S. economy. Excuse me. Over $40 billion just with hip and knee replacements. And the goal with medicine now is to reduce costs and improve outcomes. And some of the stuff we're talking about today may be able to do that. So, what is a good outcome? The issue with the hip and knee replacements is if you have multiple joints, you're diabetic, you have some heart disease, maybe some COPD, you may not do as well as somebody that's healthy and just has, one bad joint. Fairly large study in Canada has shown that. So once again, you're going to do really well with a knee replacement if you're pretty healthy and you have really one joint that's bothering you. If we start getting into multiple joints, what you feel in regards to your outcome may not be as well as you were expecting. Got one dozing off over here. I'm looking at you. So the population in the U.S., we continue to live longer lives, so there are more people to treat with arthritis. So that is an issue for our economy. We're also putting on more weight. It is difficult to maintain a normal weight in the U.S. With the availability of food and electronics to keep us busy. So we have an aging population. We have a population that's gaining weight, and that leads to larger expenses. You know, we can't replace all the knees and hips in everybody. Virtually impossible, and I don't think we'll have enough surgeons to do that. So we have to think about some other options. And as I mentioned, this is an exorbitant amount of the GDP of the U.S. Low back pain, also a large cost to the U.S. Second most common reason to see a doctor. A variety of things can cause pain, degenerative disc disease, your back goes out on you. It's typically a disc injury. And once again, conventional treatment is rest, NSAIDs, physical therapies, and possibly a steroid inject in your back. And once again, for back pain, fusions typically don't work well. It looks like they result in a poo outcome. I need to fix that typo. Poo or poor. Yeah, if you had a back surgery, you'd probably say poo outcome. Okay, so now we're going to get into a little more depth into exactly what is PRP and BMAC. So, within your blood, in simplistic terms, you have a variety of different cells. You have the plasma, which I'd like to call the soup, and then you have the cells, red cells, white cells, and platelets. Makes up to about 5,000 milliliters, 5 liters. It's about 7% of your total body mass. We can take your blood out of your body, run it through a centrifuge, and separate the blood into different products. And this is PRP. We can separate the red cells, the plasma, and then the platelets kind of sit in between. So platelets, and this is an activated platelet under electron microscope, are involved in a variety of different processes within the human body. So if you cut yourself, platelets are released, and they're there to heal you. So they can stop bleeding, hemostasis. There's also a variety of different growth factors, cytokines, and they can be involved in the immune process also. So when you take a look at a platelet, there are a whole bunch of different types of cells within the platelets. Coagulation factors, adhesion molecules, the chemokines I talked about, the regulators of growth and angiogenesis. And then specifically in these alpha granules, the red ones, those are where the healing properties are at. There's also some of the coagulation factors that can help with healing. So once again, we're taking your own blood, we're concentrating it, and we're going to help with that degenerative process of arthritis. So this is a safe, same-day office-based procedure. And basically what we do is a venous blood draw. You know, if you've seen your family doctor and they go and ask to get labs, it's basically the same thing. We mix it with an anticoagulant, and we filter it, centrifuge it. Depending on the type of procedure we're doing on you, we may give you IV sedation to make it more comfortable. And then under X-ray or an ultrasound, we're going to target what we think the painful area is. So on this little pictogram on the right, we have the broth on the top, and then in between we have the fluffy coat, which are mostly the platelets and some white cells, and the red cells on the bottom. And it's the middle layer that we're using to help heal you. So PRP initially was used, I would say, probably about 15, 20 years ago for tennis elbow. Very good research on that. So any tendon problems, quote-unquote tendinitis, it's actually more of a degenerative tendon than an inflamed tendon, can be used in the patella, rotator cuff. We've had success in a variety of types of osteoarthritis, be it in the knee, shoulder, thumb, wrist, hip, and ankle, and then also good relief within the spine. So here's a small video of what the PRP process actually looks like. So a venous blood draw done sterile. And then we place it in the centrifuge. Excuse me. Typically makes 2 different spins at different speeds. And then here's the patient's PRP. It may be hard for you to see, but we will be aspirating the PRP. Once again, you can see the yellow broth on the top, the platelets in between, and then the red cells on the bottom. So here's the aspiration process. Typically, the PRP is probably going to be around an hour procedure total once you get in the room. Here we're washing the cells back and forth. And then under X-ray, we're doing a hip joint injection in this gentleman. And he's pretty happy with me because he's still golfing. And there's the needle in the joint, and then the PRP is placed in the arthritic hip joint. The PRP we can do in two different forms depending when we place it. We can do one without white cells. We can do one with white cells depending if it's going into a joint or a tendon or ligament. Depends on the response I'm looking for. All right, who knows what that is? Bone marrow. Pretty tasty. You can't eat a lot of it though. So, two different types of bone marrow within your body. You have the spongy red, and that's the one I'm going after for the procedure. Then you have your yellow marrow, which is your reserve, your resting marrow to save you if you ever need, an event of a severe injury, extra marrow release. So within marrow, this is basically your almost, I would like to say, the soul of your body. You have all the different cells that are going to differentiate into different blood products. So we do have platelets there, precursors to lymphocytes, different types of T cells, B cells, red blood cells, white blood cells. So when we access the bone marrow, we are getting platelets, and there are a variety of other cells in there that can also help with healing. And then we also have the quote-unquote stem cells, mesenchymal stem cells. They're a very low number. We do concentrate them, and they have the ability to differentiate into different types of cells, be it bone, cartilage, muscle, tendon, ligament. But what we're actually doing with the bone marrow aspirate, we are breaking up blood vessels, and now what we know is that there are these cells on the blood vessels that are kind of messenger cells, and they can really help with healing and tell your body there's an injury, time to kick in the healing process. And we call those periocytes. So that's a blood vessel, and once again, if you have an injury, these amoeba-like cells are released off of a blood vessel, and they really get the healing process going. So what else do they do? You can inject these cells that we get out of the bone marrow. Once again, if you have an injury, your body is going to release them. They're involved in a variety of type of healing properties. They're anti-scarring, I always screw this word up, apoptotic, which means they inhibit cell death. They are angiogenic. They can promote vascular growth. They're involved in the mitogenesis, which is cell division. Excuse me. They're involved in the immune response, and there are some specific immune cells, specifically IRAP, that has been shown within bone marrow at high levels to help with the healing process. And they also are involved in the antimicrobial process, which is very nice because there are certain areas in your body that we're placing a needle. We really don't want you to get an infection. And the bone marrow aspirate concentrate is its own, basically, antibiotic. So just like the PRP, the bone marrow aspirate concentrate, the BMAC is a same-day office-based procedure. There's IV sedation once again, and depending on where we're placing it, we may or may not give you antibiotics. We do an X-ray guided bone marrow aspiration. We take it out of your quote-unquote hip, which is your iliac crest. There are a variety of other places to get the bone marrow, such as in your leg bone, but the highest concentration of these cells is in the posterior hip. So you want to make sure that you're getting them from there. You can get them from the anterior hip. It's a little more difficult, a little more risk. So we always go with the posterior hip. Once again, safest, highest concentration. Okay, so there we go. So here's a large needle in a patient's hip. That's me aspirating the bone marrow. We'll take out anywhere from 60 to 100 cc's of bone marrow. Once again, it's mixed with an anticoagulant. We don't want it to clot. And then here we are placing it in our new updated machine that we're using. This is more advanced than the one I was using a few years ago. And then under X-ray, we're taking these cells, placing them in the knee joint, placing them in the spine. Depends on, wherever the painful area may be. So I've had success with degenerative disc disease, facet arthritis, sacroiliac joints, knees, shoulders, hips, hands, ankles, rotator cuff tears, plantar fascias. I believe I'm the first physician in Michigan to heal an ACL tear with bone marrow aspirate. Patient was recommended surgery. She had neck surgery, didn't want to do it. We had a follow-up MRI, which you'll be seeing, and it's pretty impressive to see a tangled mess start to line up. So this is one of the latest and greatest advancements we have for musculoskeletal conditions. So you can see here MRI of a patient that is in this room. His lowest disc is really dark. It's degenerative. There's a little bright spot in the back, which you probably can't see. He has a tear there. Had a couple car accidents that led to this pain. We did the typical conventional treatment, physical therapy, pain medicines, steroid injections. We're only getting a few weeks of relief at the end. So I spoke with him, said there's this new novel treatment out of a quote-unquote stem cell injection into a disc. We proceeded with it, and as I mentioned, he's still getting relief, a few years out. On the other picture, we have a patient that was recommended a 5-level fusion. Once again, these two patients had their treatment at about the same time. To date, he still has not had a fusion of his spine. He had to have a little bit of bone cut out at this lower level because he was getting a pinched nerve. But he's 60 to 70% better. And this, the fusion would have ruined his life. He wouldn't be able to remain employed, and he's still happy. And we're going to be doing his knee pretty soon because he's so happy with how his back went. Excuse me, I'm getting over a cold. So here's the ACL tear. This is one of my patients from out on the lake shore. So here's her tear. It kind of looks like a jumbled mess. Severe pain. Could barely flex her knee. Could barely walk. Limped. She tripped over a trailer and tore this. And then this is the view approximately 3 months after we treated her with a BMAC. You can start to see the fibers are starting to line here, where here it kind of looks like a gobbly mess. Over here, you can really start to see the fibers are starting to line. She's 90% better. Once again, no surgery. Here's a patient that may or may not be in the room today. Excuse me. I think I was the third or fourth physician that she's seen. Given a variety of different diagnoses, we tried some blocks. No luck. MRI showed some swelling within her bone. And now we're really starting to advance treatment into treating the bone. And we're getting great results. Specifically for knee arthritis, this is ankle arthritis. We've got her walking now. She had a hard time walking for over 2 years. She had a couple follow-up procedures to try to tighten up the ligaments on the inside and the outside of the ankle. But once again, office-based procedure. We were able to keep her fairly comfortable. And 2 to 4 weeks out, walking with minimal pain. Here's a gentleman in his 70s, could barely walk a block. We did bilateral bone marrow aspirate concentrate into his knees. I've got him walking up to 2-3 miles at a time now. Pain relief within 2 to 3 weeks, and he's a couple years out. Here's a patient in his 50s, had a complete rotator cuff tear, severe shoulder arthritis. Electrician was recommended shoulder replacement. We elected with the BMAC into the shoulder. He's about 1.5 years out, still working with minimal to no pain. So those are some of my really good successes. Success rate is fairly high. I would say the failure rate is maybe 10 to 20%. It works better than steroid. It lasts longer than steroid. It's your own body healing itself. Currently, Medicare doesn't cover it, unfortunately. Hopefully someday we'll get there. I keep bugging Blue Cross and Blue Shield and Priority Health to cover it. Unfortunately, they're still not. If you've had a work injury or an auto accident, I would say probably about 3/4 of the time I can get them to pay, sometimes with the help of your lawyer. Otherwise, we have a care credit card that can give you no interest for a couple years, up to a couple years. Out-of-pocket cost for the PRP starts around $600 or so. The BMAC can get a little pricey, can be a few grand. That's about the national average. If you're out on the coast, you're going to be paying 2 to 3 times that. But I think it's a worthwhile investment, specifically with the BMAC, because I'm getting people with one treatment are getting 3 years at least of relief. Pretty good study coming out of St. Louis for knee arthritis shows people are about 40–50% better with treatment, and it's holding at 2 years. So these are some of the latest advancements in musculoskeletal care. We'll be taking questions now.